Thank you, Norma. I want to thank Dr. Friedman, Dr. Hurley, thank everyone who is a part of our TRDRP project. I'm super excited to share some results with you, and I deeply apologize for the technical difficulties. There are two studies that I'm excited to share with you. There are two clinical studies. One is a more controlled trial, and the other one is our implementation study, where we're actually working closely with the Department of Mental Health and Department of Health Services, really to, in the county, to really improve the accessibility of tobacco smoking cessation treatment. So I think both of those trials would be of great interest to our providers. While Norma's pulling up the slides, I'm going to tell you just a little bit about myself. I am a clinical psychologist by training, and I am a professor at UCLA in the Department of Psychology. That's perfect, Norma. I really appreciate it. Yep. And I've been at UCLA for the past 15 years, mostly doing clinical studies that are applied to alcohol use disorders, other substance use disorders such as tobacco use disorder, and we've done quite a bit of work also with methamphetamine use disorders, so things that are really prevalent in our communities. And so I'm going to go ahead and get started. If we can get to our first slide, Norma. What we really are going to be talking about as a background before we kind of get into the clinical trials per se is the importance of diverse samples. And there's been some really great work suggesting that, unfortunately, a lot of our clinical research is not representative, because we find that individuals with alcohol use disorder and also with nicotine use disorders, individuals with color, tend to be excluded from a lot of these trials, or not recruited at the same rates that we recruit our participants for a large host of clinical trials. So recruiting minoritized populations in clinical trials really is an important mission, and it requires an understanding of a host of barriers and facilitators to clinical research. And so I'm very excited to share with you some of those details. And what we did as our study, we spent a lot of time, partnering and identifying groups that would be interested in our research, and also making our research more friendly, if you will, and culturally sensitive to accommodate a diverse population. So I'm going to get started. Our next slide really gets right into the trial and the idea that we're going to be working in this first trial with basically individuals who are heavy drinking smokers. So I want you to think about patients that you have in your practice who are interested in smoking cessation. And what you will find is that there's an overrepresentation of individuals who drink heavily among individuals who are daily smokers. So the reason why we really focus this first trial on heavy drinking smokers is that they are overrepresented, in terms of the relationship between tobacco and alcohol is so strong. And we see that in a lot of our samples, the smokers drink more than the average population, and individuals who drink are much more likely to be smokers than controls. So we also find that basically 1 in every 4 individuals who are smokers would qualify in this criteria of heavy drinking smokers. So I want to really call your attention to all the clinicians who are listening to us, really call your attention to the fact that this is not alcohol use disorder plus tobacco use disorder. This is really, folks who smoke daily and who drink heavily, which means that they have, for women, 7 or more drinks per week, and for men, 14 or more drinks per week. So you can see how that catches a really large group of participants, and that's what we enrolled. We also find that when individuals are trying to make a quit attempt and they drink, they're trying to quit smoking and they drink, they're much more likely to then resume smoking. So the drinking itself becomes a big impediment to their smoking cessation. But if you look at the guidelines right now and you're saying, okay, what can I do for folks who drink and smoke? You're not going to find much support, if you will, for any particular intervention. The only thing that the current guidelines say is you should advise individuals to reduce their drinking while they're trying to quit smoking. So you can see there's really not a lot for us to work with, and that's unfortunate. So in our next slide, we talk more specifically about the treatments and why should we use varenicline and naltrexone. And we know that varenicline is the field standard, if you will, or the best pharmacotherapy that we have out there to support smoking cessation. It's a partial agonist of alpha 2 beta 4 nicotinic acetylcholine receptors. And what it does for a lot of patients, it really reduces their craving pretty dramatically. But there are also studies that show that if you give varenicline for drinking reduction, you actually find that individuals who want to reduce their drinking and are given varenicline, they do much better than those who receive placebo. So there's evidence that varenicline, while most of the evidence is for smoking cessation, it also helps with drinking reduction. And when you go to, one of the experiences I do want to highlight, I see quite a bit with a lot of participants, is that they are sort of a little bit on the fence when it's time to quit, because we're looking for people who are motivated to quit. And that's a really difficult state as you're talking throughout the day. We know there's a fleeting moment of motivation to really quit smoking, and then individuals say, oh, maybe I'll try again next year, or oh, this is not the right time. But what we find is when individuals start to receive varenicline, they naturally, because those receptors that are occupied by nicotine essentially are being occupied by the medication, they start to forget to smoke. They start to miss their smoke breaks. They go many, many hours without smoking. And all of a sudden, those patients who are a little bit on the fence about making a quit attempt, they say, wait a second, this is working for me. Maybe this is the time to make a quit attempt. So I really want to emphasize that, because a lot of us, have patients who are starting medications and we're trying to advise them, but they have all these kind of different interests or behavioral, comorbidities or, psychosocial circumstances. And we want to give people a chance to try the medication. We do think that for a lot of the patients we have seen, we're going to give them a good chance of recovery, a good chance of smoking cessation. Finally, I mentioned naltrexone, and naltrexone is primarily tested for alcohol use disorders, approved by the FDA for the treatment of alcohol use disorder. But we also have trials using naltrexone as an adjunct to smoking cessation, and finding that it does help, and it particularly helps heavy drinking smokers quit smoking. So it's very exciting that we're working with two medications in combination, both of which have evidence for their primary indication being nicotine use disorder or tobacco use disorder for varenicline, and alcohol use disorder for naltrexone, and we're working with them together. So let me tell you a little bit in our next slide about our study design. So as I mentioned earlier, it's very important for us to have a really robust recruitment and to be representative of, the communities that we want to serve. So this is a diverse set of participants, 165 of them. You can see in the little graph that we randomize them, which means we give them a medication. Then the little arrow, the black arrow there, indicates that we also then go ahead and give them a brief motivational interviewing session to really get them going, as far as receiving the treatment. If you go back to that slide, Norma, I'll tell folks that we then have the medication on board for 12 weeks, and we meet with our patients at 4, 8, and 12 weeks, and we collect, this is a pre-COVID trial, so we collected their expired carbon monoxide level. So everything here is biomarker verified. And then at 26 weeks, which is the 6-month mark, they are no longer on the study medication, but they're still providing a biomarker for us to verify whether or not they quit smoking. So, we did not have any interruptions due to COVID in this trial. We finished right before COVID. And this paper is published in the American Journal of Psychiatry. So of course, you're welcome to look at it and email me if you have any questions whatsoever. So the next slide is just a consort diagram. It's just going to show you essentially how many people we have interviewed, how many people we have randomized to receive either varenicline plus placebo or varenicline plus naltrexone. So, we don't have a pure placebo condition. They either receive varenicline plus placebo or varenicline plus naltrexone. And that was exciting for us because we love to be able, this was also before varenicline went off, a patent. So it was really exciting for a lot of patients who maybe did not have the resources to take this expensive medication to take the varenicline arm on an open label. So that was a really good tool that we had for recruitment. Everyone was getting varenicline, and we're just really testing whether adding naltrexone or adding placebo would make a difference. So we're very excited about this trial. We had a lot of positive responses from the community. Folks were excited to use varenicline that was quite expensive while still on patent, and that part was entirely open label. So think about this as really very much a treatment study that we think can happen in any community setting, which is you talk to someone about quitting smoking, you advise them about pharmacotherapy, you have them start the medication. They don't quit right away. They have a 7-day titration period for some of those pharmacological effects that I was talking about to kick in. So you're really going to see a nice kind of reduction in cravings, reduction in smoking naturally. And then you then have your quit date, and you have follow-ups to see how they're doing. Really important in our community to use biomarkers. I think our participants really appreciate having that. So of course, we can talk more about making those types of resources accessible, because the CO monitor is very accessible and very useful in that context. So finally, let's get to our results. So our next slide, we start getting into our results, and we start to kind of show you what kinds of participants were recruited. I hope that you see in the slide that this is a very diverse sample. We have about 30% white, Caucasian, about 40% African American participants, and about 15 to 20% Latino. So very exciting to see that sample. They drink about 20 days out of the past month. So they drink fairly heavily, and they drink approximately 6 to 7 drinks per drinking episode. So we didn't require them to have an alcohol use disorder, but we did see that they were drinking quite heavily, exceeding kind of the minimum bar that we, set at the inclusion criteria. In the next slide, we get right to our findings. I'm excited to share that with you. So remember, we were saying, when we add naltrexone to varenicline, we are going to see better smoking cessation. And what we found was actually the opposite. Patients who got varenicline alone did quite well and did better than those who got varenicline plus naltrexone. And so when you look at those cessation rates, I remind you that's a 6 months. That's the gold standard for any clinical trial. And we're really excited to be at 45%. So with this really diverse population, and there's a lot of studies questioning whether, diverse groups respond equally as well to smoking cessation, we found 45% of them quit at 6 months. So that was a very gratifying thing for us to see. And when we added naltrexone, then that number went down to about 26%, and that difference is significant. We do think that it was harder for participants to have both medications on board. We also found that there was a little more discontinuation of the medication, and nausea is a primary side effect for both medications. And when compounded at the 50 milligram rate, it was possibly an impediment. That's something that we talk a lot in our discussion of the paper. Now, Norma, if we go to our next slide, I think we'd be excited to see that when we look at drinking, so now we're switching the outcome from smoking to drinking, and in the yellow bars or orange bars, you have the combination group that got varenicline plus naltrexone, and the blue bars you have varenicline alone or varenicline plus placebo, pardon. And what you see is that they all start, as I was telling you, about 6.5 drinks per drinking episode at baseline. That's the starting point, the BA in the graph, right? The baseline. But look how much change we see at 4 weeks, 8 weeks, and maintained at 12 weeks and so forth. We see that they go to about 4 drinks per drinking episode when they have now varenicline plus placebo, and to about 3 drinks per drinking episode when they receive varenicline plus naltrexone. So the benefit of the combination that we did not see with the smoking cessation becomes much more apparent clinically in terms of the drinking reduction. So again, something exciting for us to see, and I love to see that start at 6.5 drinks going to an average of 3.5 if you combine the groups. So we really are making a difference, and that's very exciting with these clinical trials. The next slide will show you basically a separate paper that we have, and I'm happy to share with you, where we use as a clinical drinking outcome, instead of looking at drinks per drinking day, which is the graph that I just walked you through, we actually look at the World Health Organization risk drinking levels. And what we find is that when individuals receive the combination of varenicline plus naltrexone compared to varenicline plus placebo, there's a greater reduction in risky drinking according to the World Health Organization. So it's very important for us to have a host of outcomes to look at. We see that even in the smoking cessation trials, there's trials that are showing reductions in smoking as an important health outcome. And this is a really important area in the alcohol research arena, is to not just look at, total abstinence, but look at health improvements. And we think that the risk drinking levels can be useful in that regard. So thank you, Norma, so much for showing us this. I want to walk you through our next slide, and I'll go through this relatively briefly. You can see that we're changing now to analyzing brain scans and functional neuroimaging. And I want to emphasize that what we found in this, we used the same participants who completed the clinical trial. So we're really excited for that. And what we found in a subset of those participants is when you combine varenicline plus naltrexone, you reduce the salience in the brain of alcohol stimuli. So when we show visual pictures of beer versus water, or an alcoholic drink versus juice, we find that the participants' response to that stimuli within the reward circuitry in the brain is reduced by the combination of varenicline plus naltrexone, and that's not found for varenicline alone, and that's not found in the placebo condition. So we're excited to share that as a possible mechanism for the benefits of the combination when our patients are seeking to reduce their drinking. Finally, for those of us who are interested in sex differences, I want to walk you through our hypotheses that maybe phases of the menstrual cycle may play a role in how individuals respond to medication. So what you're seeing on your screen right now is a study by by Rejoice Green, who's worked with us. And actually, sorry, this very first study is preliminary data from Dan Roche, who was also a postdoc with me. And for his dissertation, what Dan showed, if you look at, we're comparing essentially placebo to naltrexone, and then you have a group of men, and the group of females is divided into the follicular and the luteal phase of the menstrual cycle. And what you can see is that in the luteal phase of the menstrual cycle, we find that the females in the luteal phase had a much stronger response to naltrexone. And that response was actually in adverse events. Because of the hormonal changes associated with the luteal phase, these female participants were very sensitive to the adverse events from naltrexone, including nausea, fatigue, and that was not seen for women in the follicular phase and not observed for men. So the question, if we go to our next slide, is like, how do we make sense of that for our female participants? And so, the next figure that I have in the slide is really showing you what's really going on during the luteal phase. Well, in the luteal phase, what you're looking at is a balance between progesterone, or P4, and E2, which is estradiol. And in the luteal phase, what you see is progesterone ratio is much higher than estradiol, whereas in the follicular phase, it's the opposite, right? So the hormone balance kind of crosses over. So then we generated this hypothesis that if we look at females in the luteal cycle compared to the follicular phase of the menstrual cycle, what we would expect to see is a stronger response to naltrexone, because that's what this study has shown before with healthy individuals, both men and women. But in our sample, in the same group of folks who completed the clinical trial, we didn't know if that stronger response would be better efficacy or just more side effects, right? So in the next slide, we'll show you what the results are. And I think you'll be excited to see, Norma, if we go to the next one, you'll be excited to see that for our participants, when we look at the drinking levels, you can see in the graph, what we have is the progesterone to estradiol ratio, right? So when the ratio is higher, it's showing that luteal phase. And you can see that in the luteal phase, individuals who receive varenicline plus naltrexone have very high abstinence rates. So we're trying to predict abstinence there, and they have very high abstinence rates compared to females receiving the varenicline plus placebo. So it was really important to account not only for the medication that they received, but also it appears as though being in the luteal phase, having this very high ratio of progesterone to estradiol as a biomarker indicated a better clinical response in the trial. So we're very excited to explore those sex differences in our study. And we especially like the opportunity to be more pragmatic in looking at something that's actionable for providers, such as identifying phases of the menstrual cycle for the initiation of pharmacotherapies, such as naltrexone, that interact so strongly with menstrual cycle hormones. So next, I want to turn your attention to some general conclusions. So there's a nice discussion when our paper came out in 2021. It also came with a nice discussion about, cigarette smoking, heavy drinking, the opportunities for combination treatment. I think they did a really nice job discussing our findings. But basically, what I want to emphasize is that adding naltrexone to varenicline had the expected effect in drinking reduction for these heavy drinking smokers. So we do see a benefit for the drinking outcome, but the opposite was true for smoking cessation, that attenuated the effects of varenicline for smoking cessation. Then we did these mechanistic studies that I shared with you, showing the brain substrates of alcohol craving and how the combination was more effective than monotherapy or just varenicline alone or placebo alone. And then finally, we found that, the luteal phase of the menstrual cycle is associated in our female participants with a better clinical response marked by higher levels of abstinence during the trial. Now, in summary, what we think is that this trial supported varenicline, not the combination, but varenicline as a possible first-line smoking cessation um, and um, for heavy drinking smokers from diverse backgrounds. And I know I got a note in the chat, and I apologize for referring to men and females. It's for males and females. So thank you for catching that. I really appreciate it. So again, the take-home message is there's nothing out there for heavy drinking smokers other than the recommendation to reduce drinking, which is very hard for participants to do. So we do think that varenicline alone should be considered a first-line treatment for smokers who also drink heavily. And that's really something that we've gotten a lot of consensus in the field for. So I really appreciate the opportunity to kind of work, in this trial, because we are really affecting 1 in 4 smokers. Heavy drinking smokers are not, a tiny subset of all smokers. So that's what I wanted to share with you. And then I wanted to go, I know we are short on time, and I apologize for my technical difficulties, but I hope you're going to be excited to see this next set of slides. And I only have about 5 slides to share with you. What I want to share with you is this implementation study, and I want to give all the credit to Dr. Friedman, Dr. Hurley, Norma, really folks. Luz Rodriguez has been working incredibly hard. Tasha Dixon has been doing smoking cessation groups. It's a really big team effort, and I'm just fortunate to be looking at the data, but the credit is really to the team led by Drs. Hurley and Friedman. And what they really set out to do, in I think a very visionary way, is to test whether we can really improve the uptake of smoking cessation interventions in LA County. And we're working with both, public health and also mental health settings. And so it's really important because we are seeing more and more that the public health burden of tobacco use disorder is really intertwined with disparities, and under-resourced communities really need to have the same opportunity as other communities to benefit from the clinical advancements in smoking cessation. So this is part of the implementation trial. Is not the entire trial, but some very exciting parts of it, where we're going to test whether being part of the intervention group compared to TAU, or treatment as usual, is associated with changes in the prescription rates that we're seeing for smoking cessation in our local clinics. So this is data from our communities, and I know several of you are really participating in this by encouraging your clients or patients to participate in our trial. So we want to thank you for that. The next slide gets right into what we're really trying to model. So very data rich, and we want to thank Dr. Martin Lee, who also went through a lot of data here. Lindsay Meredith is the leader in the paper. She's a graduate student with me. If you look at this graph, you're basically looking at periods of time and really the sheer number, like 400, 600, 800, sheer number of prescriptions written in primary care. And you can see in the color bars, you can see that basically these individuals are either receiving nicotine transdermal film, varenicline oral tablets, nicotine inhalation devices. So you can see exactly what's being prescribed to the patients at those times. And now we get to the specific question: was this variability somewhat explained by the intervention, the implementation science intervention that's really disseminating services such as behavioral counseling and medications for tobacco treatment in these clinics? So our next slide gets at that. Norma, what we have there, as you will see, is a division of the prescriptions. And now we have this blues and reds, and the red dots and line is associated with the TA, or treatment as usual. And in blue, you have the intervention, and those are total prescriptions in primary care. And what we're finding is that the clinics that are associated with the intervention are prescribing more in primary care than the treatment as usual. So we're really having an effect in terms of making these treatments, making providers more willing, if you will, to write these prescriptions that ultimately we think will have an impact, a great impact in their likelihood of success with smoking cessation. The next slide gets at mental health. So here now we're looking at our mental health clinics. Again, we have a very sort of clear picture, and I'll point to your attention that the red and the green, the blue is a little bit different this time. So we have the intervention in red and a very sharp increase with more prescriptions in our mental health clinics. Those are prescriptions for smoking cessation. And here we're looking at the change from baseline. So these clinics are writing 50, 100, 200, up to 300 more prescriptions than they did before the intervention started. And so that's very exciting for us to see. And so finally, and we see that these are statistically significant differences. So that's really important. In our next slide, we want to kind of essentially summarize what we found, which is that, there's support for the effectiveness of this community-based implementation intervention that promotes prescribing smoking cessation medications with the potential to really reduce health disparities. Of course, there are multiple ways in which this intervention is having an effect, creating awareness, creating a pipeline of individuals who are trained and aware and focused and ready to make a difference when it comes to smoking cessation. We have behavioral interventions in the clinics, thanks to all the work that's being done as part of this project. So there are many ways in which this project is impacting the clinics, but in the future we would like to explore more of the prescriber and clinic level features to see what's really making a difference. Is it their training, their attitudes, and maybe the leadership? What's really helping us increase these treatments, access to treatment? And ultimately in the large project, we're going to look at individual patients of the mental health and health systems in our county and what their smoking cessation has been. So with that in mind, I just want to thank you for your time. I'm sorry I ran a couple minutes over. I want to acknowledge my lab. Lindsay Meredith has done a phenomenal job writing up this paper, and give her all the credit. And as I said, this final paper is really the beautiful work by the TRDRP team, the Drew University and Friends Research Institute collaboration with Drs. Curley and Friedman as leaders and PIs. And I just want to thank you for letting me be a part of this exciting and meaningful work. Thank you.
Thank you so much, Dr. Ray. We do have one question here. Although alcohol intake was reduced, the individuals were still drinking, and it appeared the effects plateaued. Any comment? Also, what would be the mechanism of this reduction?
Yes, we think that the mechanism of the reduction is really more the brain mechanism of reduced salience of alcohol stimuli. That's the first part. To the plateau, I think these folks were motivated for drinking reduction. They were not seeking abstinence. So I do want to say that these participants, this was not kind of an abstinence-based trial. And in fact, alcohol use disorder wasn't even a requirement in the clinical study. So, I think that has a lot to do with that kind of plateau. One way to look at the plateau clinically, it's kind of like the gains were maintained. So, it's a kind of half glass, the glass half full versus half empty. I see it more as half full, in the sense that even after the medication was discontinued, if you look at like weeks 16 and 26, you still see that they're drinking less than baseline. So that's a little bit of a maintenance, if you will, of the effects are, really staying with them longer. There's some durability to it. But you're right that we can be a little bit more ambitious, if you will, with regards to the drinking reductions. It just has to do with, drinking goals for a lot of our participants. That's a great question.
And then why was the effect of naltrexone alone not studied in comparison?
Yeah, this was a large NIH study. We randomized 165 participants and over 4 years. And they really did not, we had a naltrexone alone group. That's a great question when we wrote the grant, but it turns out that, of course, it's very hard to do these ginormous trials. And when we looked at the power analysis and the number of patients we would have to have, they told us that we should really emphasize the two groups.
And then we do have a question here. So in terms of participant recruitment, were any LGBTQ plus identities included in the population diversity? And were you tracking gender inclusive of cisgender and transgender folks, or was that actually a sex demographic?
Great question. We did start this trial, I want to say 2016, because I do remember that was actually 2015, because my youngest daughter was born 2016. So I do remember that, we started that a while back. We did have some, planned data collection and, and I do apologize for, not being more inclusive in our representation of the sample. We have since, adopted different practices. When we started the data collection in 2015, we were a little bit more, if you will, like a little bit more, traditional with some of the ways in which the demographics were collected. We're a little bit more kind of using, data, if you will, measures that we do have some qualitative data for the participants, but we did not, have it in sufficient detail to report in the paper.
Thank you. And then just Dr. Kozlovich and then Anna Nunez just mentioned challenges. So challenges for people that drink and smoke in residential treatment centers, and then among LGBTQ plus communities where bars are usually a safe space. And then the last question we will go through is, would you recommend these products for those under 18?
That's a great question. I think Dr. Hurley, as a prescriber, can tell us a little bit more. There have been studies of the adolescent brain when it comes to these pharmacotherapies, and there's some acceptability. The main concern that I would have, especially with varenicline, is it does have, a potential interaction with depression, vulnerability, and suicidal ideation. As we know, this is heightened in the young brain and adolescence is a period where we're unfortunately seeing a lot of suicidal gestures and attempts. So I would be cautious from that perspective. I will say, when it comes to kind of challenges, and I completely relate to what's being said about, really the comorbidities, the disparities, all the factors that really can get in the way of successful smoking cessation. Part of why I'm especially proud of this trial is that we had really compelling smoking cessation rates, with over 40% of our sample being comprised of African American participants. In the beginning of the trial, people were like, "What are you doing?" There's studies that show that African American participants are not responding as well to naltrexone, and here you have 40% of your sample. And I think that with 40% of our sample, we can say that did just as well. I'm so proud of that 45% quit rate when we're looking at, varenicline plus placebo. And I think it goes to show that we need to give everyone equal opportunity. And that's really what we're, trying to do, especially so in the implementation trial in the community. So I think that these conclusions are rash, when it comes to minoritized populations, and often ill-informed because there's not enough of a sample to really draw conclusions from.
Thank you so much, Dr. Ray. We really appreciate all the information that you have enlightened us with today. Thank you so much.
Thank you, and thank you for your kindness and patience with my technical difficulties. I truly apologize, but I'm accessible via email, and the slides we make available and papers can be made available. So I'm email away. So thank you for all that you do.
Okay, thank you.